sure I know how this works. Well, maybe that doesn't work. This is the wrong philosophy of computer. I can't even find the right arrow. Oh, let's see. There we go. And then, voila. Okay. We're going to have fun with this. Gerhard, pick up the microphone because I'm going to put you on the spot as we go. So this is one of the critical things on that slide is no commercial conflict of interest. So does that eliminate me from, if I was at the American Academy of Orthopedic Surgeons and I was on one of the big panels and the room was full, would I be up on that panel if that was on my slide? Yes or no?
Politically, you're not correct. So in answer to the question, majority have conflicts of interest for sure.
Yeah, to the order of plus minus. If you look at one of the big panels at the American Academy of Orthopedic Surgeons discussing the newest, latest, greatest in knee replacement, do you need a robot? Does the implant need to be made out of kryptonite? Do you need a CT scan before you do the operation? So you got a panel of 10 orthopedic surgeons up there. Of the 10, how many have commercial conflict of interest?
I'd say 95%.
Yeah. And what do you think if you take that panel and calculate mean and median of their yearly compensation from industry, what would those numbers be off the top of your head?
I think the more famous you are, the more conflict of interest you're going to have.
That puts you on the spot. Dollar amount, man. This is in the literature.
This was between 6 and 10 are the average number of conflicts.
10 million?
No, 6 to 10 conflicts of interest.
Yeah. But I'm talking annual dollar amount. How much mean? Just mean. I'll only
$1 billion at least. $1 billion.
You're talking about the combined panel or
combined panels?
Combined panel. Okay. Yeah. And you're talking annual?
I would say, depending on who it is, there's certain members on a panel that can have 40 or 50 conflicts of interest, and they're all getting royalties on those.
Okay.
The more famous you are, the more you have conflicts of interest.
Okie doke. I love this. Are you aware of the term cobaltism?
Pardon me?
Are you aware of the term cobaltism?
Yes, I am.
Okay, cool. How many in the room have ever heard of cobaltism? Okay, so cobaltism is just the systemic toxidrome of cobalt. Certainly done in the past 10 years in the world have had a chrome cobalt head. Shoulders, hard to find a shoulder arthroplasty that does not have a chrome cobalt head. And I know this because when I go in and do a revision for this type of problem, there's very few companies that will offer me a titanium alloy alternative. Knee replacement. Gerhard, what percentage of knee replacements done in the world over the past 20 years have a chrome cobalt component?
90%.
So why do I know so much about this? I know so much about this because in March of 2006, after 10 years of symptoms, I could not do endurance athletic events anymore because my right hip was arthritic. And what was my specialty area of interest? Hip replacement. At that time, I'd been collaborating with Dartmouth Biomedical Engineering Center as a revision surgeon. I had sent them 500 to 600 explants for explant analysis. And I had all the big hitters, or many of the big hitters, from the Mayo Clinic and elsewhere to Alaska to talk at my annual meeting. And, first I was doing it just kind of, hey, you had this kind of screwball guy, he's in his late 40s, and, basically he's having to take a tramadol before he rides his bike home from the office, and he does ultra endurance races. What type of joint would you put into him? And at that time, the heavy hitters from the Mayo Clinic would say, oh man, that's a problem patient, and they said, well, probably ceramic on ceramic, maybe. And, about half were saying metal on metal, some were saying outright surfacing, which is metal on metal. And even guys who had been in practice a long time and were skeptical about newer technologies, like, is it Miguel Cabanella? He's a great Mayo Clinic, has been around forever, and, even he was saying, oh man, nutcase like that, doing all those cycles, maybe you want to involve, not avoid polyethylene, because at that period of time, the cross-linked polyethylene is relatively new in our experience, and we weren't really certain that that was going to be the answer. Well, the bottom line is I showed up at my residency program in the spring of 2006 after having a correspondence with Tom Ellis, who was out of the same program, fellowship trained in joints. I never did a fellowship in joints. I had 3 years of extensive orthopedic surgical experience before I started my residency. And my chief, Rod Beals, who's revered as being a scholar and a scientist, he basically, Tower, you don't need to do some screwball year of fellowship because, you're very well trained. And I was coming back to Alaska and I was going to have to be practicing general orthopedics in addition to trauma, pediatrics, and everything, infections, feet, everything else under the sun. That was my focused interest area, particularly revision hip surgery. And what I wanted a hip that would not need to be revised. Because I think that is our primary goal with arthroplasty. You want to put something in a person that will last their lifetime. Second thing is, for hips, so back in the day, Garrett, you're doing a lot of primary hips. What is your number one worry during that first 3 months to a year after a primary total hip? Your number one complication where you had to bring the patient into the ER, maybe not back to surgery, always happens at 2 a.m. And it's usually an old lady getting off the shitter.
Dislocation.
Yeah, absolutely. So as orthopedic surgeons, we have this fear of dislocation because it's what gets us out of the bed. Patients are not terribly happy with a dislocation, but often, oh boy, again, Garrett, what size head were you putting in a hip replacement when you first started doing primary hips as a surgeon?
They were between 22 with the Charnley and 28. And they were defined as being low friction arthroplasties by Charnley.
So out of the hip replacements we are doing in the United States today, in a 60-year-old moderately active individual, how many of them do we know will outperform the Charnley at 20 years?
I revised the Charnley 50 years later recently, and it was put in by either Mueller or Charnley. I can't remember. But we don't see that longevity, particularly in the days where we had low density polyethylene. It's more with the high density, and they say they're going to last 30, 40 years, but we don't have that follow-up yet.
Well, when I was making this decision about what sort of hip was going to be, I mean, my research started, when I was a general medical officer in the tertiary referral hospital in Alaska before residency training, because I've got a curious mind, and we were doing arthroplasties, and I was reading about all this stuff. So I'd been consuming a lot of information over many years. And when I had my total hip done, I was the first guy in Portland, Oregon as a resident to use an SROM at the VA, because we were more or less in our infancy in revision joint replacements. And the old staff guys, they didn't know what the hell to do when you came in with a really bad polyethylene lysis case with bone loss. And have you used the SROM?
I was the first one in the country to use it after you, Cameron, in Canada.
Yeah. Great book. Cameron's book on revision. One of the best references on revision surgery. It's that thick. So anyway, I didn't go into this blind. I had researched my options. Thomas Schmalzried was the design surgeon of the ASR. He came to Alaska for a dog and pony show 1 year before I had my hip. So I did my research, and one thing I knew about metal on metal hips was, in all the research going back to the 1970s in the McKee-Ferraz, it was absolutely documented that you put a metal on metal hip in somebody, their systemic exposure to cobalt is there. And I did an internship year, a very painful one in internal medicine. And I knew that cobalt was related to cardiomyopathy. So I knew it was not benign. So when Tom Schmalzried, it was cute. When Tom Schmalzried came to, we're talking 35 millimeter slide carousels, puts his first carousel in, starts to give the talk. Stryker had brought him up to pitch their knee replacement. So what was his first talk on? It wasn't Stryker knees. And you should have seen Jeff Vaughn's face when he paid the freight to get Tom up here. And the first talk he gets is on the Depew ASR. And then he switches over to the Stryker triathlon, whatever the fuck. I'm sorry. Watch my language. Whatever the du jour Stryker product in knees was at that time. So this goes to Gerhardt's comment. The guys at the front of the room often have multiple conflicts. They are the Ron Pompel for multiple companies. And it's not late night TV. It is the front of the American Academy of Orthopedic Surgeons. So Gerhardt, when you show up for one of these panel pro-con panels with the heavy hitter star guys, how full is the room?
Usually pretty full.
Yeah. So if you are in the scientific session presenting a 4-minute paper on a common complication of any chrome cobalt implant, how much time are they going to give you?
Usually about 4 to 6 minutes.
Yeah.
They call it rapid fire for a reason.
Yeah. And how many people will be sitting in that room?
At most 20.
Yeah. My experience, exactly. So the bottom line was, so here's what Tom, so I put the screws to Tom. I said, Tom, this increases cobalt levels. There were issues with the McKee-Ferraz in the 70s. Do you have any concerns about systemic issues with cobalt? So what was Tom Schmalzried's answer to me?
Probably no.
This is the exact quote. Steve, how can something measured in parts per billion possibly hurt anybody? Now, I mean, clearly Thomas had never heard of plutonium. There's many things measured in parts per billion that, can kill you. So anyway, anyone sitting in this room who does not have a chrome cobalt implant is not taking mega doses of B12, which is quite popular these days among the population and rarely has any specific indication unless you have pernicious anemia, has a blood cobalt level of 0.1 parts per billion. So I pinged out a couple of years after my hip replacement at 122 parts per billion. At that time, I was suicidally depressed and was not able to get out of bed for a week. And so my personal experience with this was an existential one. And I had to figure it out myself because nobody else was prone to believe me, even though I was a couple of years into my illness. So this is my ASR hip. This is the explant analysis that I am passionate about. This is how we learn. And I think we are failing if we are taking these things out. So Gerhard, I'm just really picking on you.
See that?
Yeah. So you're doing a tumor case. Do you ever take the tissue and throw it away and not send it to pathology? Have you ever done that?
No.
Okay. So how many joint replacements have you taken out during revision surgeries or whatnot? Thousands, hundreds?
About 5,000.
Yeah. How often have you done explant analysis?
Well, our interest was with other things, but we've done probably, I'd say, a couple hundred.
Yeah, cool. And that's exceptional.
Yeah, nobody else. We reported on them, but for certain other problems like infection with the ulcer, and we did explant analysis and determined it was a biofilm-based infection that caused all the problems.
So was it really related to oil?
It was because of sterilization. They use electrons, surface electron sterilization. And what's the perfect protective layer that you would have if you're trying to oxidize the organisms with electron beam or electrons?
How much crosstalk? So the sulzer was a metal on, or also could be a metal on metal, had a metal on metal, had the Duras, it had the Metasol, and it could be done, I believe, metal on plastic as well.
What happened?
But with the issues, was the metal a confounder to that, or could they say absolutely it was the sterilization?
It was inadequate sterilization. There, I can give you a good example. We did explants at Montana State University. What the oil did was protect the bacteria from the electrons, because the perfect absorber of electrons is something that can be oxidized, which are petroleum fuels.
Well, the word,
all of them were.
The word on the street was, I never heard infection mentioned. What I heard was aseptic loosening of the socket.
It wasn't from the oil. It was a low-grade infection, and Larry Dorr was the one that was honest about it. 15% had infections associated with it, but it was a pure biofilm-based infection. So you couldn't culture it. You can only see it on confocal laser with live dead stains. You could see it on surface analysis with high-powered SEMs or skin.
So this was because of a sessile organism or one specific
It was a pure biofilm. The biofilm was the only area that survived. So when they went back to do the explant, they fell out, but it was all secondary to infection. Another good example is, remember the Dow Corning breast? They attributed it to silicone. Well, it happened. I was coming back from Oxford and I talk on biofilm. The guy next to me was a quality control for Brazil, where most of them was done. They had to back off on the radiation. And when you analyze it on the surface, and we published this with Costerton in 2012, it was loaded with biofilm-based infection. With the Sulcer Medical, I called them up. I said, look, this is an infection, and you know about the class actions associated with it. So they said, well, we want to talk about it. So they met at the place we used to have the HKS at the airport in DFW. I walk in, I thought it was going to be scientists. It was 25 different attorneys in front of me. And I just turned around and walked out, called Costerton and said, we have to publish it this week. Otherwise, we're going to be subpoenaed for the rest of our life with the explain analysis.
How many people in this room have ever heard of Google Scholar? Pretty much everybody. So everyone in the virtual world, and probably about half of you who are younger than I is on your phone, go to Google Scholar and type in cobalt urea. The first two hits are going to be our last two papers. JAMA, talking about what total joints are high risk to elevate urine cobalt and therefore blood cobalt. And the more important publication, if you only want to read one, read the one we published in December, because that not only covers everything that's in the JAMA paper, but it also covers a patient symptom inventory that you can use to figure out whether Aunt Nellie is a French fry short of a Happy Meal because of cobalt, or whether it's just normal aging, which is how this most commonly is attributed to when it happens. But this is, most all the references I give in this talk are open access online. So we're having so much fun, Garrett and I, I'm going to breeze over what's in those papers. Because the big issue here, and why this talk I think will be important to not only the audience, but potentially into the future, is not only what is this problem, what is the epidemiology, how do you treat it, but for God's sakes, how did it happen? Because we knew about this in 1975. Lucas Jones published in none less the Journal of Bone and Joint Surgery, a paper called Cobalt Toxicity from McKee-Farrar Hip Arthroplasty. So Garrett, you're on the hot seat again. In all the multitude of papers supporting by Amstutz, by Schmalzried, who was the guy in Britain with McMinn, because of some men arthroplasty. So the reason the metal on metals came back, what drove that was hip resurfacing. And surgeons like myself, who did not want to go and do a special course, didn't have to want to learn a new trick, and who were very comfortable putting in a femoral stem, most all the companies that were offering metal on metal hip resurfacing were offering basically the same bearing that you could put on, a femoral stem that as a surgeon, I had trust in. In addition to that, there was one specific, so what's this one specific thing that can be a short-term, largely short-term, potential short-term technique related with hip resurfacing or patient selection, or could be late, that you're not likely to see if you put a stem in?
Listen, one thing.
More catastrophic, because it's a structure that doesn't exist as a bone with a femoral stem, but still exists with the hip resurfacing.
Not sure I understand the question.
Femoral neck fracture. Femoral neck fracture. It's a weak link in the femur. What did Osler say? Into the world, under the pelvis, out of the world, through the neck of the femur. So, this is, the most common technical short-term complication of a large head metal on metal articulation on a stem. And a lot of it early on in the resurfacing experience was technique related. And, so what happens, when this stuff takes off, and some hard-hitting surgeon with a nice contract from industry, when they publish, their first big series saying this is the greatest thing since sliced bread, are they reporting their first 50 cases, or are they reporting their case series from 200 to 1,000.
Usually small case series.
But is
Usually
it,
smaller.
but is it their first 100 cases?
Usually not.
Usually not, but there's something called learning curve.
Correct.
And you can really hurt patients with a learning curve. So anyway, this is my odyssey, only I think the odyssey was only 10 years. And I'm 14 years into this. So so the bottom line is, and you don't have to read the paper, you just need to watch Grey's Anatomy or the Netflix documentary, The Bleeding Edge, because the average person on the street who watches the medical soaps knows this exists, whereas their orthopedic surgeon does not. And that's a function of a couple of things. Their orthopedic surgeon is very busy, doesn't have time to watch the soaps, because the average orthopedic surgeon believes that panel at the academy, which has severe conflict of interest. And frankly, it's from a phenomena well described all throughout human behavior. If you're talking about ozone, you're talking about climate change, you're talking about tobacco, you're talking about oil rigs blowing up. And that phenomena is called willful blindness. If you are heavily invested in something, anything, you can shut your eyes and not see a big common problem because it's extraordinarily inconvenient psychologically to accept that. So my hip came out after 42 months. I knew this was cobalt. At 18, I knew this was cobalt 12 months after the hip for a couple of reasons. One, the hip started to hurt. Two, because I'm by nature an intellectually curious individual. So when my hip started hurting a year after, I started measuring my blood cobalt levels, baseline with exercise. I couldn't believe it. I never got charged. I never had a problem with the labs. But the cute thing was my blood levels were in the literature that was there looking, and these devices were getting incredibly popular in the mid 2000s. They were very commonly used device, particularly in certain areas. So when I first started checking my levels, first level I got, I had a cobalt level of 42. If you look at, that's 420, a factor of 420 times what the average, Joe would have without an implant. And it was, if you look at the literature that was supporting this technology, so you're a research surgeon, you're doing blood and urine cobalt levels. And you have these pesky outliers with extraordinarily high cobalt levels. And you think this technology is great, and you're going to make a ton of money. How are you going to report your series? Are you going to use means or medians?
The majority of surgeons do not report on bad outcomes. We've encountered that on trying to get publications on bad outcomes associated, well, as you're well aware, metal ion allergies. And it's been really hard to get it into into any one of the major journals. We're publishing in Outliers, but open forum so that we can get it on the marketplace. Good example, getting it past those people, usually in the 2-stage revision for infection, I had to give 200 support articles and at least 300 or 400 lectures to get it accepted as a gold standard for treatment of PJI. we're encountering the same thing with the metal ion allergies. In fact, when I was announced, giving the talk at this disaster plasty, the first thing they said, this is a very controversial paper, and they didn't want to hear about it.
Yeah. Well, my controversial paper was what happened with me in November of 2009. I knew I was cobalt toxic. My crazy manic decompensation, where I trashed a hotel room in Hanford, Washington, where I was speaking at a signed nail conference, was my attempt with a diseased manic mind to get my voice heard, because I knew thousands, probably tens of thousands of individuals. I knew about 1 million to 2 million of these had been put in, and I am wired to scream anytime I detect preventable harm. And at that point, I had exhausted different efforts to get Depew, who made my device, and my colleagues to recognize that maybe it wasn't good to be walking around with cobalt levels that were in the double digits. And I was pretty damn well connected, because I had run a meeting in Anchorage, Alaska, that every hard hitter wanted to come to, because they wanted to come to Alaska. So I knew Dan Barry. I knew the whole Mayo team. I knew Doug Dennis. You know, these guys are respected as being authorities in that field. So knowing Dan Barry pretty well, and he and I graduated Dartmouth at about the same time, it's very easy for me to communicate with Dan. And I also knew he was a design surgeon for Depew. And so I sent an email to Dan, who was going to be in Africa doing a safari, while I was in Africa teaching a signed nail and setting up a fracture program, and said, Dan, and yeah, at this point, I'm kind of disguising that I'm the patient. Dan, I've got a patient who's highly athletic, and he's got a blood cobalt level of 50, and he thinks he's getting a little squirrely. Could this be related? And Dan goes, well, first Dan gets really defensive. Oh, you know, Steve, I'm not the metal on metal guy. You know, that's Tom Schmalzried. I said, Dan, I have you on speed dial. I don't have Schmalzried on speed dial. Could you please talk to Tom about this? And then sometimes later, no, you know what? Tom actually thinks cobalt's good for you. You know, it might be improving, you know, your athlete's athletic performance. And then I go, you know, since I'm well connected at Dartmouth Biomedical Engineering Center, I call up Dartmouth and talk to John Currier, who's a good friend, classmate of mine, and really the beating heart of that lab. And so he was a working engineer, not the professor. And unfortunately, we lost John about 3 years ago from lung cancer. So, you know, I called up John, and Dartmouth Biomedical has this very precarious tightrope situation. Industry funds a lot of the labs, but they also very much feel motivated to publish, you know, on complications and problems. Sample of that is Doug Van Sitters is presently the professor at the lab, and we talk maybe once a month and shoot, you know, just what's going on. And I'm concerned as kind of the curmudgeon old guy in town, and I get new surgeons coming out of fellowship program, and I talked to Gerhard about this. They're routinely slamming in 40 millimeter heads on a primary hip. They're not doing any sort of testing of stability profile. So given the restricted territory of the acetabulum, what is the consequence of slamming in a 40 millimeter head on everybody?
To get a 40 millimeter head with either Depew, the old Pinnacle Cup, which is part of the Echelon the philosophy, you have to go to the 64 outer shell. And that's too much bone resection, number one. Number two, the frictional rates are higher for the bigger heads. And the wear down rate of the poly is going to be increased if it's poly. You would assume the same thing would be true metal on a metal.
They're not over reaming. So they're putting in a 50 cup and they're putting in a 40 head. So how thick is the poly?
Very thin. And that's the part that wears out.
So if you're dealing with a 40 head, as opposed to what you and I came out of when we started practice, putting in, say, a 26 or a 28, what is the difference at the forces at the neck stem trunnion? So what's happening at that interface?
Now you have hoop stresses because of the worn poly.
No, I'm just talking about head trunnion.
Okay.
We've moved to the femur side. So we're looking at that tape. When was the last time you put in a monoblock femur such as a Charnley?
Long time ago.
Yeah. So, for total hip now, we're always accepting modularity at the head neck. So, and those tapers were designed, they weren't designed for 40 heads. So we're seeing huge issues with trunnienosis and taper failure. So we've had a great time. And just going into this, I mean, when this all, I realized this was going on, and I was crazy. I thought I was on a mission for God. Once I got my senses back, I realized this was not a mission from God. It was Louis Pasteur. Chance only favors a prepared mind. I had just published on catastrophic failures of polyethylene cross-link if you make the poly too long. As I just said, this ain't new. We've known cobalt's been toxic for a long time. It's a mitochondrial toxin. Those were the joint replacement case reports that preceded mine. They were not from the present generation of metal on metals. These were from the McKeefer-Oz. And if you have a ceramic fracture revised to a chrome cobalt head, you get retained ceramic debris, which becomes an in the body abrader of the femoral head. This is a presentation. Encephalopathy, peripheropathy, cardiomyopathy, endocrinopathy, polycythemia, very rare, and only when the cobalt levels around 1,000, and autoimmune syndromes. This is Eric Wobear. He's the surgeon I said I was worried about because now he's slamming in 40 heads. He was a rising second-year med student when we published that paper. It included explant analysis. I think explant analysis is critical. If we're throwing those parts away, it's like being a tumor surgeon. You're not sending the tissue to the pathologist. Eric was on this paper too, 2015. I said, everyone's saying this is rare. I don't think it's rare. So we had 25 cases identified. A few years later, they found 75. When my patient paper got published, all of a sudden you see an exponential rise in case reports. Is that because the incidence is really increasing, or is it because people are opening their eyes? It's because people are opening their eyes. So we're up to 14 peer-reviewed publications, but a lot of surgeons haven't heard of it. This is my most recent one. This was last week. And so that's gross taper failure. That's a 44 millimeter chrome cobalt head. Initially, when that started, this is a recalled implant. And the reason it was recalled was the distal taper, which dovetailed into a titanium alloy stem. And those corroded, poisoned the patient, adverse reaction to metal debris. All of those I've seen are failing on both sides because they have taper corrosion on the other side. That's because the Stryker V40 taper was designed for the Exeter stem, which was stainless steel. Integral to taper design is the stiffness of the material. The V40 should never be used in any instance other than the Exeter. It is a piece of crap. And, this is my wake-up call to cardiomyopathy from cobalt. This fellow was batshit crazy. He was relatively young, but was still doing powerlifting. I put in bilateral V40s, 32 millimeter chrome cobalt heads. He did fine, but he developed iliopsoas tendonitis on one side, increased fluid, increased blood cobalt, increased cobalt in the periprosthetic. And at this point, I'm getting wise and I'm screening all my patients with echocardiography. And I got him in. He had no symptoms. I saved his life with a screening test because he had a ascending thoracic aneurysm. Taper corrosion, metal on metal. This is a survey. You find the survey in the +1 article. I've seen this before. This was my patient. I did the primary. Same as the other fellow I just showed you. Look at the bore of that head, polished, and the end of the trunnion has bottomed out in the bore of the head. It's like a mirror. Another one, this is how it presents. That's the clinical syndrome. Look at the +1 paper. This is the Beanie report. He's been faculty this meeting. Great meeting. You're going to get that when you read the JAMA. This is an example of the early stuff. On this one's really interesting. That metal bearing has worn in millimeters instead of microns. And you see the same issues with resurfacings. These are my problem tapers, the V40, which is a total piece of crap, and the Zimmer 1214 with a 32, even a 32 millimeter head is a piece of crap. The Rejuvenant, this has become a popular implant. Dual mobility, chrome cobalt liner, Stryker product, piece of crap. It corrodes on the acetabular side, poisons people, adverse reactions to metal debris. We published on this, snake in the grass. Mechanically assisted corrosion, well fixed, polished chrome cobalt. And you can see the degree of corrosion, poisons the patients. Shoulders are in trouble. They are a high-risk device. And the Hemis, the Riemann runs, are probably the highest. We're publishing on this, which is from failed spinal. I'm seeing it in bilateral knees, and the way that Gerhardt's describing it as an autoimmune syndrome triggered by relatively low levels. You're going to get that out of the papers. The brain imaging, you can diagnose a cobalt encephalopathy with great specificity with an FDG PET brain scan if you use a computer analytic program called NeuroQ. That's an open access paper. You just go to that, all you need to know to figure it out for your patients. So the bottom line is orthopedic implant cobaltism is a spectrum illness. If you see a case report, you multiply that by 100,000 or 250,000 if you look at the spectrum of the illness. And we're dealing with a worldwide at-risk population of 40 million. It's common. Do the math. This you can get out of the +1 paper. Easy to do. Takes me 5 minutes to screen a patient. Urine cobalt's an easy, quick test, and you don't have to stick the patient. But you have to remember to take them off of high dose of B12 or you'll get a falsely elevated. You can treat most patients with N-acetylcysteine. It's over the counter. It chelates and it mitigates the intracellular mitochondrial toxin. If I got someone who's really sick, I gild the lily and I throw in glutathione and alpha-lipoic acid. There is some good support from that. You have to remember, patients can have trouble at the hip as well. If they have the hip trouble, you need to do source control and revise that. This is just a review of the relationship of blood and urine. We're sticking our head in the sand. I tell you, you don't want to be a Cassandra. It's really a bitch of a role. And if you're the only one who's screaming, you basically get gaslighted. And you start to think you're crazy. And it doesn't help if you are crazy because you have cobalt brain. This is my point, about the quote. And I thought the AOS was great. I thought it was an honest broker of science. It's not. It is marketing disguised as science. Here, do the math. Josh Jacobs says, oh, this is rare. Well, Josh, come on, you're a scientist. 2 cases out of 1 practice in Anchorage, Alaska. You just do a little math and figure out how much of the population that represents and what the multiplier is. Sweet Jesus, Josh. I don't know how much Josh was getting paid. He just got the Tipton Leadership Award at the Academy. He's a good guy, but he's got the blinders on. These are great books. The lower ones, Willful Blindness, Merchants of Doubt, and The Woman Who Knew Too Much. If you want to understand why this happened from a social standpoint, those are the books to read. And I apologize for being over time, but I was on a roll. And I'll blame it all on Gerhardt. That guy, oops, sorry.